how we deal with these delayed onset tissue nodules that are inflammatory. And I have a protocol in that we tend to use. And be careful, we know that antibiotics don't tend to work, and steroids do, but we're not brave enough yet to do one without the other, because you still could have both. And the thing is, you could make a mistake by giving steroids to a patient who has an infection, and it'll get worse. So, I mean, we used to say, well, give them like clarithromycin, doxycycline for 2 weeks, see how they go. But most of those patients, in my experience, do bugger all, you know. And I mean, I have no problem doing that. But I would tend to do the two at the same time. Put them on oral steroids, normally dexamethasone, 4 milligrams a day for about 5 days. See where you go. It may disappear. It may come back. If it does, you know, you're then in a situation where you don't really want to use hyaluronidase because you're going to start off from scratch again. And there is a possibility that if you clear with steroids, the patient may retain their volume in their face. So we move into interlesional steroids. And so these are the sort of problems that we see. Sorry, that patient there was obviously from before. So normally I'd start off with depamedrone. It's 40 mg per mil or 80 mg per 2 mil. And don't inject it directly into a face, or you're going to get lipoatrophy and dermal atrophy. So you run it at 50% dilution, or if you're not sure yourself, 25% dilution. You'll not run into problems at that level. Obviously, 50% is better for the granuloma ones, but the ones that have just kicked off and, you know, they're a bit hard, but, you know, you can sort of still get something into them, probably run them at 25% dilution. So, I mean, it's easy enough to pick it up. I'm down to 35 minutes, so better, I suppose, watch my videos. So normally, you would take your
mix it with
hyaluronidase,
saline, as a lot of people are doing.
put 1 ml of bacteriostatic saline in it.
Would actually be quite painful.
It's not sore then.
And what we normally do is add.
And if you want to add lignocaine, particularly during a vascular occlusion, that's fine. It's a vasodilator. It saves any pain. Don't obviously use xylocaine with adrenaline, or you could make things worse. So if you take that, you've got 1,500 units now in a syringe with 10 gradations. Your optimum thing you want to work with is 75 units, and that's nice and easy. So what you can do is twofold. You can take the 1 mil, empty out half it, draw it back up with bacteriostatic saline, so then each 0.1 is 75. That's an easy way of doing it. Or if you want to add in, at that stage, also depamedrone, just 0.1, 0.2, that's about 4 milligrams, and make the whole thing up to a mil. That's a nice mixture to use. Anyway, I've been through that. So when you start off first, obviously you try and massage these things, you might even give them a nick. And believe it or not, a lot of them will be like this, where you have to sort of give a nick. Now, the problem is, when you're dealing with a mid-cheek, it's on the bone. It's behind the zygomatic muscle. And that's a problem, because you normally, if you're in a hospital scenario, would want to do a big cut and a washout on somebody's face, and you're going to leave a big scar. So probably the best thing to do in that sort of situation is grab the zygomatic muscle in your hand, give a little nick that's not going to cause, I suppose, any adverse aesthetic effect. Get a blind probe and go all the way down to the bone with it, wiggle your way around, get it out as much of it as you can. So you want to minimize the scarring. And unfortunately, I don't blame our hospital colleagues. They don't want to see patients back, but they can go for gold, and the patients end up, you know, sort of with other problems then. So if you've time to play because you're in a private scenario and you can see the patient again, so give them a nick, do a washout if you can. There's possibly infection there also. So, I mean, be careful with bethadine. Some people can be allergic to it, particularly if you're going to go retrozygomatic. But if you get, you know, sort of a blind probe and go through the zygomatic, make your way through, you'll get most of these patients. And I mean, so you just have to play with it for a while. And the nick you're making isn't much bigger than if you were drawing blood. So if you get an 11 sort of blade and you go down about a third way on the blade, that'll not leave a mark behind. So that's where we are. So you're below the zygomatic muscle when you're doing it. You're wasting your time otherwise, because you know that most mid-cheek are super periosteal. So, I mean, if you're going above it, you're not going to get it, and the patient will just be back to you. So that's, I suppose, a case study, but you'll get loads of those. Then, if you overdo it, and you've no choice, then the patient's going to come back to you, suddenly one cheek raised and the other not. So where do you go from there? So the first thing is probably don't use the problem products, which there's a couple of them. Use the one that you're sort of happy with yourself. I tend to use Galderma. I haven't seen too many problems with it. Belotero, I haven't seen too many problems with. Stylage, I haven't seen too many problems with. And, you know, when the COVID vaccine came, it shone a light on all these. I was presented with over 40 cases. 23 of them we wrote up that would respond to nothing, absolutely nothing, not even interlesional steroids. And they were from all over the world. I'll show you in a moment. So with those type of cases, you can't leave a patient with one side done and the other not done. So if you're going to put in your favorite filler to replace the what you've taken out, put them on steroids at the same time. So hit them from the word go. Now, not even sure what that is. Okay, so then during COVID, I was left in a situation where, how do you treat these patients? So I was down in Uganda, and a colleague of mine, well, he's much older than me, that was Dennis Burkett, who was also from Enniskillen in Northern Ireland, was faced with that problem, and he used methotrexate for the first time on patients with Burkitt's lymphoma, and it worked. It was Epstein-Barr virus, and I was, I suppose, in a place for Portugal beyond Kampala. So we decided to try methotrexate on some of these patients, and believe it or not, it worked on almost every one of them. 21. One person dropped it because of hair loss, another dropped it because she lost energy. But if you're going to use methotrexate, three things. The first thing is, if you get somebody who's able to prescribe it, and don't be afraid of it, it doesn't usually cause too many problems. The second thing is, in the beginning, it can cause a problem. So in other words, it's an anti-chemotherapeutic drug, it's an anti-ectopic pregnancy drug, and you've got to respect it from the point of view that it's going to kick off at fast-growing cells. Fastest growing cells in your body are in your blood. So warn the patient, because it's one tablet a week, or an injection once a week, so you're not going to be there if they kick off. So if they drop their red cells, they're obviously going to get breathless or chest pain. If they drop their white cells, they're going to get infection. If they drop their platelets, they're going to get bleeding problems. So just warn beforehand. And so you monitor them closely for the first maybe 2 or 3 weeks, and then you're up and running. All you have to watch is their liver function tests, because it can cause liver problems. So the biggest problem with methotrexate is that it takes 8 weeks to work, you know. But having said that, we normally give them a shot of depomedrone in their bottom to cover you for that period. And to be fair, it worked. So I've moved now from using it there to using it just for tissue nodules, and it works as well. Not as much as COVID, I found, but certainly we got 90-something% with COVID, and this is probably sitting around late 60s. It's not working on everybody. But then I'm only using 10 milligrams. And certainly if I was dealing with plaque psoriasis or even rheumatoid arthritis, I'd be moving off 10 milligrams. So easy does it. And I'd probably switch over to using Dapsone, which is easier. But I mean, the thing is that we need the companies involved in this. Because no use the patients coming into us and we're doing this cultures and sensitivities. We need to be measuring things like inflammatory mediators, cytokines, pre-inflammatory cytokines. They're the things that need to be measured, and the companies should be involved in this. And to be fair, we have help from the companies, but really we need a setup where we're you know, I did orthopedic medicine in a previous life, and we had a situation where when we were doing disc removal, some patients still had